I struggle with cyclic vomiting syndrome. I just got over an episode, kind of getting over an episode I've had for roughly 4 to 5 days. It started on Saturday, and I think food was a trigger for this one. So when I go through my episodes, I'm at my most vulnerable. I'm on my hands and knees. I'm in the bath, in and out of the bathroom to vomit and to be in the bath. And then it goes to me being on the floor, hunched over, trying to suppress the pain from my stomach and the acid the acid in the back of my throat to stop a little bit. When my episodes happen, I immediately start taking my medication because sometimes it does help, sometimes it just doesn't. I like to think that it does, but taking medicine for cyclic vomiting syndrome is different for everyone. You have to get a ritual, if you will, a game plan of what does work for you. That way you can knock that out of the park instantly. You do not want it to keep dragging. But for me, my cyclic vomiting syndrome, it does go away by itself. And I don't know why. So to everyone who has cyclic vomiting syndrome, I know it sucks. It really does. And I'll have to make another video about me and how work and me having cyclic vomiting syndrome ties into me working and stuff like that. My name is Mercedes.
Oh, where to start? This has to be the most frustrating diagnosis and one of the most debilitating for my patients. I think the biggest problem with this whole cyclic vomiting syndrome, cannabinoid hyperemesis overlay is how poorly recognized it is in the medical community. I can't tell you how many patients I have who go back and back to the emergency room and they're inappropriately labeled as drug seekers or worse. And I think this goes back to the fact that it's very difficult to diagnose. It oftentimes takes many years. But I would summarize cyclic vomiting as follows. Think of cyclic vomiting, abdominal migraines, cannabinoid hyperemesis, and migraines of your head in a Venn diagram. There's slight academic nuances between all of them, but they're all quite similar. And as the name suggests, many of my patients have terrible nausea, vomiting. A couple points that we always try to emphasize in clinic. Number one, can you tell a common trigger that brings on your attacks? For most of my patients, it tends to be a life stressor. I'm talking about things like family gatherings, Thanksgiving, Christmas, final exams for many of my younger patients who are still in school. I have many high-functioning executives who have an attack just prior to their quarterly board meetings. So it definitely can affect all walks of life. She was mentioning that she takes medications, and we'll get to that, but there's really 3 aspects of care, meaning that we have abortive therapy, medications that you take when you feel a prodrome, when you feel an attack is coming on. We have supportive medications, antiemetics, IV fluid resuscitation, that help manage the symptoms of an attack. And then the final aspect, which seems to be underappreciated based on what I've seen, and that is prophylaxis, medications that you would take on a day-to-day basis to help prevent attacks from even starting. Let's get into some comments here and see what people have to say. Abby says, isn't cyclic vomiting mostly a neurologic problem? Do you have any family members with migraines? I like what she says here. There's definitely a very close association between family members with migraines, patients that have migraines, and those who have cyclic vomiting syndrome. I would label it as a disorder of mind-gut interaction. And what I mean by that is I think it's greatly underappreciated, the interplay between our gut, our microbiome. I'm actually getting blown up with some hospital consults right now. The interactions between our gut, our microbiome, and our central nervous system, meaning our brain. When you're stressed, we have many patients who experience gastrointestinal symptoms as a result, meaning irritable bowel syndrome, cyclic vomiting, functional dyspepsia. But it goes both ways, meaning that we have more bacteria in our GI tracts than we have human cells in our body. That microbiome plays a vital role in making many of our hormones and neurotransmitters, which then pass back through the blood-brain barrier to the brain. So this interaction goes both ways, but I agree 100% with Abby that I would label cyclic vomiting as a disorder of brain-gut interaction, and there is a common association with migraines 100%. We have another more academic video by a doctor here in the United Kingdom, Dr. Butt Gastro. Let's see what he has to say.
Syndrome is a gut disorder that causes repeated severe episodes of nausea and vomiting. These episodes can last anywhere from a few hours to several days and are interspersed by periods where patients are symptom-free. The Rome Foundation have established strict criteria for diagnosing CVS, which are used by clinicians across the globe. CVS has 4 distinct phases. So number 1 is the prodrome phase, where patients feel sick, which is known as nausea, and may have abdominal pain. Phase 2 is the vomiting phase, where patients feel very...
The only thing I would add, a lot of times during the prodrome, it's not just nausea. I have many patients who they can see auras, they can smell things that aren't there, they have floaters. So in the same way that you can have a prodrome for a migraine, so too do most patients with cyclic vomiting have a prodrome prior to the true onset of the nausea vomiting. This is very important because many of our medications, we ask them to be used as abortive agents during the prodrome, meaning that as soon as you think an attack is coming on, take some intranasal sumatriptan in the same way that you would for a migraine. I'd always tell my patients, it's better to take it too often than wait for an attack to become full-blown. So abortive therapy during a prodrome is definitely something we recommend and seems to be underappreciated based on the patients I've seen.
Nauseous and may vomit several times an hour, oftentimes for several days. Phase 3 is the recovery phase, where patients begin to feel less nauseous and vomit less. Phase 4 is the well phase, where patients are completely symptom-free. The precise cause of CVS is unknown, but research suggests that patients with CVS may have an abnormal interaction between the nerves in the spinal cord and brain and the gut. There may also be an abnormality in the way that the hormonal system responds to stress. The triggers for CVS are wide and varied and can include emotional stress, intense excitement, allergies, lack of sleep, or physical exhaustion. Treatment of CVS should be guided by a qualified medical doctor and generally revolves around the use of antiemetic medications, which reduce the symptoms of nausea and vomiting. There's also a role for identifying and managing the triggers for CVS, as well as having plenty of bed rest. In severe cases of CVS, where patients become dehydrated and are unable to have any oral fluid intake, there's a role for hospitalization and for intravenous fluid.
I think this video is good, but it's a little simplistic, meaning that I would break it down as I do for my patients in the following way. I think there's 3 aspects of treatment. One, as we were talking about, is abortive care, meaning that you take a medication when you feel an attack is coming on to abort a full-blown nausea, vomiting that can last several days to weeks. You want to abort the attack before it reaches that point. So I often give my patients the same thing we do for migraines of the brain, meaning intranasal sumatriptan. And I've heard good reviews. It helps to abort the attacks in many of my patients. The second aspect of the care is supportive care, as he's alluding to. Antiemetics, things like Zofran, Amend, Compazine, Promethazine, and IV fluid resuscitations. A lot of times the patients are having nausea, vomiting so bad that they can't replete their losses. And if that's the case, then yes, it's appropriate to go to the emergency room to get intravenous resuscitation. And the final aspect of the care, which I was just working on with one of my patients this week, and we've come a long way. I've been working with her for 2 years, and that is prophylactic therapy, medications that can be taken on a day-to-day basis to help prevent the severity and frequency of attacks. Medications we typically use for prophylaxis include a tricyclic antidepressant, as because there is a close mind-gut interaction. Things like nortriptyline, amitriptyline, we usually start low, 5 to 10 milligrams, and up titrate over time, although there can be side effects. The patient of mine I was just talking about did have suicidal thoughts with that, so we had to stop that. Another medication that can be used as prophylaxis is Keppra, an anti-epileptic, a seizure medication, but it's very useful in cyclic vomiting as well. Unfortunately, my patient didn't respond to Keppra. And so now, finally, we found Amend, which is a prepitant. We commonly see that in cancer patients getting chemotherapy, but it's also highly effective, a very high-powered antiemetic that sometimes, if taken every day, can serve as excellent prophylaxis for cyclic vomiting syndrome. But let's see what some of these comments have to say here below. Steph says, excitement triggers my cyclic vomiting every time. Concerts, vacations, weddings, graduation, etc. So many events ruined by vomiting. We definitely see all sorts of triggers, but recall that this is a disorder of brain-gut interaction. So we see many of our patients from varying walks of life. I have some students that get terrible cyclic vomiting just prior to their final exams. I have many high-functioning executives, CEOs, who get cyclic vomiting just prior to their quarterly board meetings and earnings reports. So definitely the triggers vary, but are usually associated with psychosocial stressors in my experience. Independent lady says, I have this. I told doctors years ago what it was. Now they finally listened and put me in the hospital for up to 9 days, developed as an adult. It's not very nice, very lonely to have. I definitely see patients who take years to decades for a definitive diagnosis to be made, and I think that just goes back to the fact that cyclic vomiting is not very well recognized outside or even in the gastrointestinal community. Layla says, as someone with cyclic vomiting syndrome, I've never seen any medical professional talk about it. Thank you for spreading awareness. Also, thank God for Zofran. Yeah, definitely Zofran's a good one. Ondansetron, Compazine, all excellent antiemetics. I told an intake nurse at the ER I have cyclic vomiting syndrome, and she rudely said, so you smoke cannabis? And I said, no, that's different. And she said, we use it synonymously. It is true that there's a close overlap between cannabinoid hyperemesis, cyclic vomiting, abdominal migraines, migraines of your brain, if you can consider a conceptualized Venn diagram. In many of our patients, cannabis is the root cause, and typically in those cases, they'll tell you that a hot shower immediately ameliorates their attack, but not all patients with cyclic vomiting consume THC, but most patients with cannabinoid hyperemesis do have cyclic vomiting-like symptoms. I don't know if any of you guys like to look at these Ask Me Anything posts on Reddit, but I actually found a very interesting one about a patient who has cyclic vomiting syndrome. Just like the title says, I have an uncommon diagnosis called cyclic vomiting syndrome. One of the weirder symptoms is the compulsion for extremely hot showers during an episode. Like we just talked about, I would have a high concern for cannabis consumption if there's hot showers, but let's see what they have to say. When I go to the emergency room, doctors rarely believe me or treat it correctly. It's true, it's not well recognized. And they say here, I'm happy to keep answering questions, but I will no longer entertain those who insist it is cannabinoid hyperemesis syndrome. They are who separate diagnosis for a reason. I don't partake in THC in any form, and my cyclic vomiting syndrome started when I was young. before I was ever exposed to marijuana, even secondhand. We'll see what the comments have to say, but I can definitely see why many would assume it was cannabinoid hyperemesis if the attacks are benefit from taking hot showers. They say here, what happens during an episode other than hot showers? Does it affect your daily life in a big way? What is the correct treatment, and what happens if not treated properly? The OP says, during an episode, I am hit with the worst nausea you can imagine. The only relief is when I'm actively throwing up, which is problematic as you can't hydrate that way. It absolutely affects my life. Luckily, I work from home and my job is very understanding that I'll likely have to adjust my hours around my episodes. Proper treatment for me, everyone is slightly different, is compazine and morphine with Protonix and Benadryl, all intravenous, with constant IV fluids. I usually need potassium in my IV as well. Without proper treatment, I'm just going to have a really bad time. I won't be able to stop throwing up or able to eat or drink effectively until it ends on its own. It could be days, it could be weeks. The longest episode was 3 weeks. I would ask this original poster if they're having a prodrome, meaning that can they tell an attack is coming on? Because one of the things they're not mentioning is abortive therapy, meaning that I usually like to give my patients sumatriptan intranasal to abort an attack before it becomes full-blown. Once the attack is full-blown, then it's much harder to treat. Yeah, we can give them compazine, IV fluids, Zofran, all that's fine, but ideally you want to help prevent an attack from happening in the first place. And they're also not making any mention of any prophylactic therapy, meaning a medication they would take every day to help decrease the frequency of the attacks. They say it often gets paired with pain from the esophageal ulcers. I remember once I ended up on the floor of the waiting room in the emergency room wrapped in a blanket sobbing because my stomach hurt and I was throwing up, and they just left me like that for 4 hours because it was peak COVID. Yeah, I do remember I was just finishing my training during COVID, and the amount of outrageous things I saw in the emergency room during COVID, I don't even want to talk about, but that was definitely a different time, and I'm sorry that it sounds like they were neglected for several hours, but all bets were off during COVID, to say the least. But yeah, my symptomatic phase is 3 to 5 days. Snoo asks, is this a neurologic disease or a disease of the digestive system or something else? They say it's a suspected to be neurological like a migraine. Unfortunately, it isn't that well studied. This is true. I would classify cyclic vomiting in the same group as irritable bowel syndrome or functional dyspepsia, meaning a disorder of brain-gut interaction. Interestingly, if you go to a large tertiary care center in a major city, you may note that many of the gastroenterology professors are actually dual appointed in psychiatry. And you may say, that's a funny combination. What does psychiatry have to do with gastroenterology? Well, like cyclic vomiting, so many of our GI diagnoses are actually disorders of the brain-gut interaction, meaning that the brain is sending abnormal signals to your gastrointestinal tract, to your gut, and then their microbiome, they probably have dysbiosis, they're not eating enough vegetables, the variety of vegetables in their diet is poor, so the microbiome is not producing the adequate hormones and neurotransmitters to send back through the blood-brain barrier to have a healthy brain, and so the cycle goes. They say here that my doctors told me mine is from smoking weed. Do you consume cannabis? They say I don't touch it. Cannabis is associated with cannabinoid hyperemesis syndrome, which is different from cyclic vomiting syndrome. I don't smoke weed at all. It is true that technically, academically, they're different diagnoses, but they're very related and have very similar symptoms. I think the reason why they made a disclaimer with regards to the cannabis and people keep asking is because this original poster is mentioning that hot showers help cut the attack or improve the symptoms. Now, guidelines are just guidelines, but if you look at any guidelines for cyclic vomiting, cannabinoid hyperemesis, they'll tell you that if hot showers help, it's usually a dead giveaway for cannabis abuse. But in his case, he says he swears he's not consuming any cannabis, so we'll take him at his word. Speaking of cannabis,
trying to push you in one direction or another with respect to smoking marijuana. I just think that some of this information is interesting, and it's such a widely used product. Why many people don't know. I've heard many personal stories and even reviewed studies that show how it can be beneficial in one's life for a variety of different reasons. And in the same respect, I also know that it can place someone at risk for developing a substance use disorder, and both of these things can be true at the same time. But I just like some of these fun facts. For example, did you know that if you smoke or use marijuana heavily, you can have episodes of re-intoxication? So this is for those who more commonly use marijuana, but it deposits into the fat. And so in states of starvation or stress, the cannabis can be released from the fat stores and cause episodes of re-intoxication to that person. This is one of the things I didn't know. Also, the percent of THC in marijuana has significantly increased. If you look at the average numbers in the 90s, it was around 4%, and the average numbers now, after 2015, are around 17%. And some products contain as much as 90% THC. Now, that is significant.
I practice in Las Vegas, okay? So I don't know if any of you have ever been to these cannabis dispensaries, but they're on every corner here in Las Vegas. And to his point, when you go in, when you try and buy a product, it can allow you to filter by the percent THC. I like what he said, that back in the day, it was maybe 4 or 5% THC. When you buy these cannabis products now, it can go as high as 50, 80, 90% THC. So it's definitely much different than the marijuana or cannabis that was around many years ago. He says that cannabis can be a gateway drug to harder drugs. I guess depends on your perspective. I could see it, maybe not. But I think it brings up an interesting conversation. If cannabis can be considered a gateway drug, what about caffeine? There's a Starbucks on every corner. Caffeine has to be the most widely used psychotropic drug in the world. So if cannabis is a gateway drug, can caffeine be considered the same? I don't know. You decide.
As an ER doctor, frankly, I'm more concerned about other substances, but I am aware that there's one problem that is very common in the emergency room, at least in the last 3 years that I spent working in Los Angeles. And it's called Cannabinoid Hyperemesis syndrome. And if you've had this, you know it very well because it is a debilitating condition. And for reasons that we don't completely understand, it happens to certain people and it doesn't happen to others. But essentially, there are chemicals within cannabis that can trigger the brain and the gut reflexes to cause you to cyclically vomit. And it's very difficult to treat. It can be debilitating and very hard to recover from. Again, all of these facts I didn't know until I started reading and trying to learn more about marijuana. And I just, again, think that this stuff is interesting.
I think one of the most interesting things about the cannabis and why it is so difficult in some of my patients, in many of my patients with cannabinoid hyperemesis, to get them to stop, is because in the short term, acutely, cannabis does help. I've seen patients with cancer, end stage of life. It helps with nausea. It helps with pain in the short term. But as he's alluding to, it is absorbed in the fat, right? So if you go a day or two without eating, or you go into ketosis, that cannabis, that THC that's been absorbed into your fat, is going to leak out. And I think that's the core of the issue. As I tell my patients with cannabinoid hyperemesis, meaning that we've done an upper endoscopy, there's no ulcers, there's no gastric outlet obstruction, there's no cancer. We've done a CT scan that looks good. Oftentimes, I even do an MRI of the brain to make sure that there's no brain cancer there causing their nausea and the vomiting. If all that is normal and we have nothing else other than heavy THC use, then yeah, I'm going to call it cannabinoid hyperemesis. And what I tell them is that when you stop, it's going to get worse before it gets better. Meaning that you're going to lose the short-term antiemetic effects, and you're going to feel worse over time, probably a couple months before all the THC reabsorbs out of your fat. So I don't have any issues with cannabis, okay? It's none of my business. It's perfectly legal, and I don't care. And I think it probably should be legal. But as he's alluding to, we definitely see a lot of nausea, vomiting with it. And it's becoming increasingly frequent, especially as the potency, the percentage of THC goes up in these products. Let's see what a lot of people have to say here. Mayor says, I've experienced cyclic vomiting for about 5 years, but I only started smoking 3 years ago. Now the doctors insist my vomiting must be cannabinoid hyperemesis, and it's very hard to find help. Obviously, if the symptoms started 2 years before this individual started consuming cannabis, then it's not cannabinoid hyperemesis. But if you have these disorders and you are concurrently consuming cannabis, then that's the first thing the doctors are going to tell you. So although it may help, my recommendation would be to stop, because it's probably exacerbating the situation in the long term and not doing Mayor any favors. Neurospace Girl says, I have experienced reintoxication episodes before and had no idea it is a real thing with a name. Happened to me at my corporate job, almost had a panic attack. I can just imagine Neurospace Girl in the middle of a meeting in ketosis, probably fasting, suddenly gets high again. I hope that the meeting went well. As a heavy smoker, I think getting facts out there is important. People should be as knowledgeable as possible to consume responsibly. 100% agree. So I hope you guys found this educational. I would say that there's a very close relationship between migraines of the brain, cyclic vomiting, which can be seen as abdominal migraine spectrum, and cannabinoid hyperemesis. I think these disorders are greatly underappreciated. I have many patients who would go undiagnosed for years before they see me in clinic. I would emphasize that there's really 3 main categories of treatment. One is try to identify a prodrome, meaning that can you tell an attack is coming on? Do you have any symptoms to let you know an attack is about to be full blown? If that's the case, then definitely ask your doctor about any abortive therapy. We usually use sumatriptan nasal spray during the prodrome. Number 2, supportive care. We're talking about things like Benadryl, intravenous resuscitation, Zofran, ondansetron, compazine, promethazine, or I've even started using Amend, aprepitant, in many of my patients. It works great, 80 milligrams a day. And then finally, ask your doctor about prophylactic therapy. We're talking about things like tricyclic antidepressants, nortriptyline, amitriptyline. You can try anti-epileptics like Keppra, or the antiemetic Amend can be taken every day as prophylactic therapy to help reduce the frequency of the attacks. I think that gradually the medical community is becoming more accepting of cyclic vomiting. We don't have a cure, but I agree with everyone who's saying it's a disorder of the brain-gut interaction. Common triggers include psychosocial stressors, holidays, family meetings, board exams, school, finals. Try to identify those triggers because you can use the abortive therapy at those times. As I always tell my patients, as we begin to work and accept this diagnosis and manage it, it's also important to have reasonable expectations. I don't think it's reasonable to say I want to be 100% cured. I will never have another attack. I think it's much more reasonable and feasible to simply decrease the frequency and severity of the attacks, decrease the impairment on their day-to-day life. From a positive standpoint, I do think it's becoming more accepted. I have many patients who do well with therapy and recognition of their triggers. I hope you found this video beneficial, and if you or any of your loved ones suffer from cyclic vomiting or cannabinoid hyperemesis, leave a comment below. Otherwise, I think I'm going to release a video on hemorrhoids next. I know many of you out there have hemorrhoids because I see it all day in clinic. It's probably the most common complaint I get. But otherwise, I'll see you in the next one.